Hi, good afternoon, everyone. A very warm welcome to all of you on behalf of Abbott to this program on Win Over Inflammation CME. Win Over Inflammation CMEs are a series of 6 webinars that we are planning to conduct in collaboration with top orthopedic surgeons to educate and upgrade the skills of orthopedic surgeons across India. This is the first program, and a warm welcome to all of you. For today's program, I would like to introduce you to the speakers. The first speaker for today afternoon is Dr. Neeraj Bijlani. So Dr. Neeraj Bijlani is a consultant orthopedic surgeon. He also handles trauma, spine, and joint replacement and is attached to the Orthotech Clinic. He's a senior consultant with over 20 years of experience and is an esteemed speaker of AO Trauma International and CCOT. A warm welcome to you, sir, Professor Bijlani. The next speaker for today is Dr. Shiv Shankar. He's a senior orthopedic consultant with over 28 years of practice. He's currently the president of the Indian Orthopedic Association. He has developed several new techniques and instruments in orthopedic surgery. A very warm welcome to you, Dr. Shiv Shankar. The third speaker for today evening is Dr. Parag Sancheti. Dr. Parag Sancheti is the chairman and managing director of the Sancheti Hospital and has been associated with the Indian Association of Sports Medicine, IASM, since 1996 and is serving as a president of this association. He's also the founder member of the Indian Society of Hip and Knee Surgery. A very warm welcome to you, Dr. Sancheti. Now, without further ado, I would request the first speaker for today afternoon, Dr. Neeraj Bijlani, to come on stage, please. Over to you, Dr. Bijlani.
Thank you very much. So I have been going to talk on medical management of osteoarthritis. So all of you who are orthopedic surgeons do know that osteoarthritis means degeneration of the cartilage. And this is just the brief overview of the anatomy, that how these structures look when they are normal and how they start degenerating. So what I'm going to talk is about grade 1, 2, and 3. And not about grade 4. Grade 4 and maybe 3 also, Dr. Shiv Shankar and Dr. Parag Sancheti will be talking more in detail. So what is the pyramid of management of osteoarthritis? Of course, it starts with something non-pharmacological, that we have to tell the patient that you do your exercises, you prevent injuries, try to do weight loss, use orthotic devices like braces. We give them topical NSAIDs, capsaicin, lidocaine patches, which are not so commonly available in India. And then we ship them to oral. That is the stage when actually the patient comes to us. They have already tried topical and non-pharmacological. Or many have not tried non-pharmacological, they come to us. And these are the drugs which we would like to give them. And then we can offer them something like an intra-articular injection. About the surgeries, various surgeries, my co-speakers will be speaking. So what are the different forms of conservative management? The most important is lifestyle modification. Whenever I speak to any family doctor of the patient, I tell them that you have to concentrate, tell the patient that's weight reduction. So there was a research after the bariatric surgery came in India a few years back, that patients who had severe overweight and they underwent bariatric surgery and they lost 10 kgs, their knee pain went away. So now we know an objective figure that you lose 10 kg and your knee pain is going to reduce like anything. So you have to, of course, tell them you avoid squatting, because in India, many people have Indian toilets and it is very difficult to convince many people that you have to get a stool or make a toilet for your mother or father. About activities, I would tell them that you restrict their activities, especially the stair climbing and descending. Then we go on to pharmacological. Physiotherapy forms a main part that your quadriceps muscles become weak over the time. And that's why your quadriceps muscles and the vastus medialis obliquus requires a lot of exercise. And then we go on to intra-articular injections and knee braces. So what is my pharmacological treatment? Paracetamol always remains the drug of choice. Many people don't know that paracetamol can be given if a patient is approximately 70 to 80 kg. Paracetamol can be given 1 gram 4 times in a day. though we don't get 1 gram very commonly. So what we do is that 650 milligram 3 times a day. Then if there is an inflammation or there is swelling, I would like to give them an NSAID. It could be diclofenac, it could be etodolac, it could be atorvastatin, depending on the patient profile. Of course, topical analgesics always need to be given. And you need to diagnose the underlying disorders, like whether the pain is not because of osteoarthritis, but with gout. So you treat them with febuxostat, or rheumatoid arthritis, then you treat them with steroids and disease modifying agents. Sometimes patient comes to me with popliteal pain where they're not able to straighten their knee. They get a lot of spasm at night, calf pain. So then I try to give them muscle relaxants. Of course, nutraceuticals form in today's day and age where there is a COVID scenario, where patients are not willing for surgery. Nutraceuticals nowadays are forming a main part of my treatment. My two favorites are collagen peptide or undenatured collagen. Collagen peptide comes in the form of powder where compliance is an issue. So I have now shifted most of my prescriptions to undenatured collagen. However, it being a non-veg source, my vegetarian patients, I give them rosehip, and a combination of rosehip, Boswellia serrata, or curcumin, whatever combinations are available. Somehow I'm not comfortable using glucosamine and chondroitin, but I have used it in a combination and not as a separate only glucosamine and chondroitin. Patient somehow of mine, my own aunt is taking glucosamine and chondroitin. She gets her supply from my cousins who stay in US. Now I come to the main part of my talk, that is the intra-articular injections. So what are the different forms of injections which are available to us? There are steroids. So it is most commonly used steroid is methylprednisolone or triamcinolone or acetonide like Kinacort. There is a different forms of hyaluronic acid. The new kid on the block are platelet-rich plasma, who have been here since many years now, almost 3 to 4 or maybe 5 years. And the latest one is something called as platelet-derived growth factor, which only one company is supplying. So let's understand what is the evidence. So the main strong evidence of use of glucosamine and chondroitin by American Academy of Orthopedic Surgeons that they cannot recommend it, means they don't do it. And the other ones, NSAIDs, there is a strong evidence. So I like to give NSAIDs to almost all my patients, unless there is a strict contraindication. The inconclusive part was the paracetamol, the pain patches, or opioids, and intra-articular steroids. So the inconclusive part means that the work group is unable to recommend for or against. So that is left to the surgeon to decide whether he wants to give the injection or whether he wants to not give the injection. Again, if you go towards viscosupplementation, they are saying that they cannot recommend hyaluronic acid. Biologic injections like PRP are still again inconclusive. So it is my choice is that my first choice is always a steroid unless it is contraindicated, like a patient who's on insulin-dependent diabetes or something like uncontrolled diabetes mellitus. Now we'll come to UK NICE guidelines. Intra-articular injections, they say, should be considered adjunct to core treatments. Core treatments means like a physiotherapy. And they are also saying that you should not offer hyaluronic acid injections. Somehow the hyaluronic acid injections are not being recommended by both the American and the UK people. So what is the advantage of all these things? Corticosteroids is that fast pain settles, but it does not act prolonged. So you may have to take multiple. Use for inflammatory flares. However, I have seen in my experience when I shifted from methylprednisolone to triamcinolone in 2019 is that the inflammatory flares were much higher with methylprednisolone and is much lesser with triamcinolone. What they say about hyaluronic acid is the prolonged effect of pain relief, but it is an unpredictable thing. It may or may not work, but it is tolerated very well because there is no flares and there is no post-operative side effects in most of them. Then we come to platelet-rich plasma. There is very low level of evidence and small sample sizes. One of our ex-IOA president only has done a lot of research on PRP in the knee arthritis, and he has found quite a bit of success. So it is always suggested to use in a younger population. So I would like to use it in maybe below 55. There are no definitive recommendations. And in combination, it's supposed to, if you use hyaluronic acid and PRP, but then the cost just bombs up. So I would not use both together. So if you see viscosupplement also, there are first, second, third, fourth generations. Up till the third generation, first generation was multiple shots, then came the second, again single shot. Then came the third, which was biofermented because people are not preferring the animal ones. Third and then fourth again became single. And there is something called the fifth generation, which has recently come up, which is a viscoadaptive. So it acts as a lubricating agent in the joints, and they are supposed to have the same frequency, that the viscosity, elasticity, there is some science behind this, and it acts as a better shock absorber. However, we have to see it because it was released only in 2019 and we are still yet to see how it goes further. What does the literature say? So in again GAOS 2017, patients receiving intra-articular steroid injections had improved pain and function. So they should expect less improvement in patients with obesity or advanced arthritis. So as I was telling that grade 3 or maybe grade 4, certainly injections will not be benefited. But grade 1, 2 and even some patients in 3 where they are not so obese, they will have good relief. However, in my experience, I have even seen temporary good relief for at least few months in obese patients. But it depends from patient to patient. So I will just show you now, there are two techniques which I use for giving the intra-articular injection. The first technique is in supine position with the leg extended. I always do these injections in the operation theater. I scrub them like it's a surgery. I drape them like it's a surgery. Then the third slide shows that I am doing a local anesthetic because I want to do a local anesthetic before I put a 18 number needle, which is going to be there inside for a long time. The reason I do in supination is, or in the knee in extension, is when there is a effusion and I want to aspirate the effusion. And that is what I do. I aspirate the effusion and the fluid is completely clear like you see here. I would like to inject bupivacaine mixed with triamcinolone Kenacort. And I would like to give them in an effusion, I would like to give them a big RJ bandage, which they will remove only at the end of 3 days. My technique 2 is a little different. So I keep 2 injections ready. I have a proper trolley. I'm scrubbed up in the OT nowadays. And one is the local anesthetic, as I was telling. And the second one is again a bupivacaine mixed with Kenacort. After I've prepared everything. Then we have prepared the patient. My assistant prepares the patient something similar to what we do, surgery. So he has already prepared, scrubbed. Patient is ready. If you see, they have scrubbed the patient and they have draped the patient before I enter. And then there is Cutaset applied all over it. So I will just put a little bit of sterilium or a spirit swab. And then I will identify the patellar tendon. And just around 1 centimeter lateral to the patellar tendon, I will feel the joint space and I will inject the local 2% xylocaine in that space. And I will try to go till the capsule. Sometimes if the patient is very obese, I may not reach till the capsule, but that's all right. But at least the patient has a little bit of anesthetic effect before I inject a very thick 18 number 1.5 inch needle inside. After I have done this, I will now identify the same place, try to put it in the same place, put a 18 number needle with my mixture of Kenacort and bupivacaine, and I will inject it. After injecting it, I would want the solution to mix inside. I don't know whether there is any evidence to it, but I learned this from Dr. Parag Sancheti, one of his presentations where Dr. K.H. Sancheti was saying that if you put a lot of Sensorcaine inside, you can always just extend it and maybe help a patient relieve of the flexion deformity. And after this injection, because there was no effusion, what I would do is that I would just put a small dressing like this. With the patient will go home and remove it, and after 30 minutes and he'll apply ice to it. So my conclusion on medical management is that short-term benefit is high with steroid injections. I would still recommend, and especially in the COVID scenario, if the patient is non-insulin dependent diabetes and diabetes is under control, I would recommend with steroid injections. The new viscoadaptive supplements, if you wish, you can try, but there is still evidence lacking. PRP and newer PDGF are the future, or maybe already there. I have used PRP and PGDF in tennis elbow and plantar fasciitis, but I have yet to use it in knee arthritis. I thank you very much for your patient listening.
Thank you, Dr. Bijlani, for that interesting presentation. I now invite Dr. Shankar to start his presentation.
Share. It has become very small. No, The size, Neeraj, the size has become so small.
Yes, sir. What you can do is that just stop the screen share and just share the presentation option. Stop the
Okay.
screen share. You have kept the presentation open, right?
Yeah.
So when you click on share, you get multiple options. उसमें एक presentation रहेगा आपका PowerPoint, वो select कर लीजिए instead of the screen.
Now I cannot see the WebEx.
सर नीचे एक आइकन है WebEx का अलग से.
Yeah. This is in PowerPoint mode. That's
Just
why it's.
open your PowerPoint presentation, sir. जो भी आपको दिख रहा है ना पहला वाला, हाँ.
No. The problem is a little different. I have to open the PowerPoint show,
Yes.
so that I cannot keep it open.
No, sir. You don't open the PowerPoint show. Just open the PowerPoint file as if you are editing it.
Okay, I'll open in open new.
Yes. You can now play the slideshow. Yes, sir.
Probably will have. Sorry for that problem. We all see such patients, elderly ladies in the 50s and 60s with a varus knee, coming limping with a duck waddling gait. So regarding the HTO or the knee preservation surgeries, what we normally do, we have to take a single leg stance X-ray, and also we have to confirm that the other part of the joint is normal under arthroscopy. I normally take the X-ray, overlapping 3 cassettes together and merge them in the software which I got. This is just before doing the HTO, we have to do the arthroscopy. Coming to the high tibial osteotomy, we have extra-articular osteotomy like lateral closed wedge, partly open and partly closed, dome osteotomy or medial open wedge. Coming to the intra-articular osteotomy, we have tibial condyle valgus osteotomy. Sometimes if the deformity is more, you might have to combine both of them. Coming to the lateral closed wedge osteotomy, you remove a small wedge of bone just in the proximal end of the tibia and correct the deformity. Varus gets corrected into valgus. So this is what I used to do earlier. I used to do the fibula osteotomy and take out a wedge of bone and put the patient in plaster. To reduce the time in plaster, we can use a Coventry staple, or even you can put a small plate or even a figure 8 bandage. So these are some of the X-rays showing closed wedge osteotomy, which has given good results in my hands in the past. This is an example of partly open, partly closed. So in open wedge osteotomy, if the angle is little more than 15, where you have to remove a large chunk of wedge. In such cases, you can partly remove the wedge only from the outer aspect, and partly in the medial side, you can open it. So this is how I do them. So here in the lateral part, it has got compressed, and medial part, it has got opened again the fulcrum. So this is partly open, partly closed wedge osteotomy. That also gives excellent results in selected cases. Coming to the barrel dome osteotomy, you can translate the tibia slightly anteriorly so that the patellofemoral arthritis can be also reduced. This is one such case. Very long time back, I had operated Elizaro system, and this is, you can see, it's a slide I have taken, and this was the clinical picture of the same patient with a good correction. Then came the medial open wedge osteotomy. Instead of having to do the fibula osteotomy, without one can do the medial open wedge osteotomy. So then I started doing that with the help of Pudu plates. These Pudu plates were available from wedges between 8 centimeter to 15 centimeters wedge. So this is an example where I have done a medial open wedge osteotomy with the help of the Kudus plate with good results. This is another case where a similar type of implant has been used and a graft also has been used, as the deformity was a bit more larger. Up to 15 centimeter medial part of the cortex you can elevate without any bone grafting. That's what they say, but we are not confident to use that technique. So we try to put a graft and also to put the plate to get early movements in these patients, and good correction could be got. This is another case with early medial OA, where again with a tomofix, again it's a medial open wedge type of HTO fixed with a tomofix and got a good result. Friends, the problem with the HTO, the lateral closed wedge osteotomy or the fibula osteotomy or wedge removal, and also plaster problem. These were some of the problems which are associated with this HTO. So nowadays, I started using the fixator assisted medial open wedge osteotomy after listening to Dr. Mangal Pariyar about 10 years back. The advantage is no fibula osteotomy, no under or over correction. You can correct to the last degree. Gradual and complete correction is possible as there is control in your hands with the external fixator outside. And the most important, no plasters problem like ankle and knee stiffness. This was mother of a doctor with a severe pain in the medial joint, mainly on the right side. These are the weight-bearing X-rays confirm that the weight-bearing axis is going medial to the joint line. And I treated this patient with a HTO with the fixator assisted. This is the small osteotomy being done under the CM control. And see that on table you are able to correct completely. And the lateral wedge, lateralmost part has to be here. It has to be intact. You should not complete the osteotomy. That's the crux of the treatment. Against that fulcrum, the opening happens. This is immediate postoperative X-ray. Normally, I start the distraction after 7 days, and once the patient learns the distraction, the patient goes home. Every week they come and I take a weight-bearing X-ray and see that the correction is happening properly. Once the correction is full, I stop distracting. It normally takes about 2 to 3 weeks for that. If there is more correction, then it can be reduced by clamping the fixator and reducing the distraction. The patient is normally able to walk without any support by about 1 month's time. Prior to that, patient will be walking with the help of a walker. This is the end result in this patient. The preoperative picture and the nice alignment in the postoperative picture. You can see that the weight-bearing axis is passing through the Fujisawa point or the lateral tibial spine, where we want the weight bearing to go. This was a patient with knee pain due to malunited fracture of the childhood. Again, such a bad varus deformity. Again, you can see that I have applied a fixator and gradually distracted this. This patient had a lot of trouble because the distraction required was more, and unfortunately my pins had gone in this direction. I learned after discussing this case with Dr. Mangal Pariyar that I should have passed the pins in this direction. So anyway, in this case, I had to use one more distractor and get the distraction properly done before he could get the full correction of the alignment, as you can see in the earlier clinical picture and also in the immediate postoperative picture in this patient. Another bicondylar fracture with a treatment done with only lateral plate went into varus malunion, and again this patient came with a subluxated knee with severe pain. You can see this is how he was able to stand. And again, here you can see that I am passing the shank pin parallel to the osteotomy site, learned by the mistake of. As I said, this is immediate postoperative period. The patient is able to walk, partial to weight bearing with the help of the walker. This is the same patient after correction of the deformity. So the picture shows the full correction in this case. This is an interesting case. This lady came to me with a severe pain on the left side knee joint in 2013. I did a open wedge osteotomy with the help of the fixator. She came back only in 2019 again with a bad knee on the right side. You can see the correction on the left side, which is so good. She was still happy with the left side knee, though the X-ray doesn't look that great, but she was very happy and she came to me for the right side knee replacement. So here there are no choice at this stage because it's a bad grade 4 knee. So I had to do the knee replacement in this patient. This patient sent me the X-ray during the lockdown and you can see both legs she is able to stand unsupported without any problem, and the correction is practically same on both the sides, and the right side T-care has been done and the left side knee preservation done with the HTO, which is still going great in spite of the bad osteoarthritis which could be seen in the earlier X-ray. Recently, intra-articular osteotomy has gained more importance for much more better correction. The tibial condylar valgus osteotomy has gained it's the in thing at present. This is popularized by Tsukata Teramoto from Japan, and what they do is, if the tibial condyle surface is not flat and if it is dome like this, you can call the pagoda like, so it looks like the top of a pagoda. These cases, to increase the stability, you have to do an intra-articular osteotomy. By doing intra-articular osteotomy and getting the valgus, you can increase the surface of contact between tibia and femur and also correct the varus deformity. This is a case I borrowed from Dr. Milind Chaudhary. You can see there is a varus in this patient, and this patient was treated by tibial condyle valgus osteotomy and the C-arm control. Once you mark the area with drill bit, then because there are very dangerous vessels and nerves posteriorly, there is very controlled osteotomy you have to do. Then you open this medial tibial condyle, and once you are happy with the reduction, and once you get the reduction properly, then you can fix it with KYs and then subsequently with the Tomofix plates which are available for this osteotomy. This is the same patient after the correction of the deformity showing. See the full support of the femoral condyle, and the tibial proximal end has become horizontal, which was like a pagoda earlier. Another case, this is from my friend Dr. Samir Shah from Baroda. Again, early osteoarthritis. These are the early osteoarthritis are the right cases for doing the HTO. So, and you should learn in a very simple cases like this. Again, he has done the tibial condyle valgus osteotomy. On table, you can see that on just after doing osteotomy, the cautery line is going medial joint line, and after the correction of the deformity, you can see it is going through the joint properly. So this is how it has to be done, and it is fixed with the help of the plate. And this is at 6 months the function, and this is after 1 year. You can see the nice alignment of the knee in this patient, and this is the function at 1 year. The advantage of this knee preserving surgeries, patient can still able to squat, sit cross-legged, and the customary problems of the Asian people can be still attended to. Last part, it's intra-articular plus extra-articular, where the deformity is too much high. In this case, again, this is from my friend Dr. Milind Chaudhary. You can see he has planned properly to pick the intra-articular part with the TCVO, and extra-articular alignment he has tried to get with the extra-articular osteotomy and fixed with the electro-fixator. This is the after the correction in this patient with the electro-fixator. This is the final picture of the same patient. On the left side, you can see good correction into valgus, and you can see the weight bearing X-rays also showing good mechanical axis. Friends, to conclude, if you see a OA knee in grade 3 or only one of the joint is involved, medial or lateral part of the joint is involved, try to preserve the knee. It's always better to try to save the knee. Look for varus alignment in osteoarthritis. Consider early osteotomy. Definitely you can delay the T-care to a better age. Like the case I have done the T-care at the age of HTO at the age of 60. The patient came to me at the age of 72 for the T-care on the other side. So similarly, you can do the postpone the T-care to a better age. Accurate planning is required. Technique is accurate. You can get very good result with that. Try to solve the osteoarthritis problems of the knee by preserving surgeries before considering knee replacement. And I now hand over the mic back to the organizers for the further deliberation by Dr. Parag Chetty, who will be talking on knee replacement surgeries. Thank you very much.
Thank you, Dr. Shankar, for the presentation. I now invite Dr. Parag Sancheti to discuss the surgical management of osteoarthritis.
Thank you very much, Dr. Diksha, for this opportunity. On the outset, let me thank Dr. Shiv Shankar, our dynamic president of IOA, for really putting this together. I think this is an excellent activity by IOA, and the important thing is that it will cover a series of topics as mentioned earlier. So the role of arthroplasty in management over the various aspects of arthroplasty in management of osteoarthritis. I hope everybody can hear me well and see the screen well.
Yes, Parag. Please go ahead.
Thank you, Dr. Shiva. So if you see, the burden of arthritis in India is huge. You know, even if you say about 10% of patients are having some kind of joint pain, you know, that itself takes the number to 125 million in India. And that's a huge load to manage, especially, you know, with the number of healthcare facility centers which are available to manage this. So you very nicely saw what Dr. Neeraj showed you, the various treatment modalities. And what I've done is I've gone through all these guidelines which have been given by EULAR, Osteoarthritis Associations, AAOS, NHS from UK, and I've just tried to summarize it in this particular slide. So these are the various non-pharmaceutical therapies which are available, and Dr. Neeraj has mentioned them. Also, the pharmacological therapies which are there, which include intra-articular injections, which have been very well highlighted by Dr. Neeraj. And I think if you see, the majority of the cases actually can be managed by these two particular therapies. Today, I will be speaking to more on the arthroplasty part. If you just heard Dr. Shiva Shankar, our president here, speak on high tibial osteotomy, an excellent talk where he covered all the aspects of tibial osteotomies and patient selection in OA. And today what I would like to tell you is that, knee osteoarthritis is one of the most common condition you see in your practice. And you are seeing with all kinds of OA patients. Is total knee replacement or a partial knee replacement, which is a unicondylar knee replacement, the answer for all these osteoarthritis patients? Well, no. What I would say is about 85% of patients can actually be treated without doing a total or a partial knee arthroplasty. And these are mainly in stage 1, stage 2, and some in stage 3. But if you go to stage 4, then you might require an arthroplasty. Let us take the example of the 60-year-old lady where you can see there is joint space reduction here. You can also see that only the medial compartment is involved. So what do you do in this case? Do you do a total knee arthroplasty or do you do a partial knee arthroplasty? That's the question which you need to ask. And when we do a partial knee arthroplasty, like you call it the unicondylar, the basic integrity of the joint is quite well preserved as compared to a total knee arthroplasty. So the ACL, PCLs are maintained, the patellofemoral joint is there. So it's a more preservation kind of operation than a total knee arthroplasty. If you see osteoarthritis, it always goes through these various stages, the grade 1, the grade 2, grade 3. So these are the 3 grades you've got to see. Grade 1 and grade 2 can definitely be managed by non-surgical modalities. Grade 3, you can do either a HTO, and the indications for HTO and a uni are quite similar. But if you go to stage 4, then not even a uni nor a high tibial osteotomy is going to work, and these are the patients who are going to require a knee replacement. So it's very, very important to do the proper radiology, proper clinical evaluation, and decide whether your patient is in stage 1, stage 2, or is he in stage 3. These are the patients where you can go either way. You can try injections in some of this, as Neeraj said. You can try a high tibial osteotomy. You can do also a unicondylar partial knee replacement. But whenever you're dealing with stage 4, mind you friends, knee replacement is the only answer, and a high tibial osteotomy or a uni will not help. how do you decide? So there are certain X-rays which you always have to take as a part of your evaluation. I always like to take a single joint weight bearing X-ray. I like to take a long leg X-ray, a scanogram, which Dr. Shiva showed you how to take it, and also a true lateral view, where both the condyles are superimposing and you can see the Blumenstadt's line to confirm the position of your patella. Also, what is important is the stress views. The varus stress view you can see here, and the valgus stress view which you can see here, the joint opening up. And this is an important view for your decision making in a unicondylar versus a totally, and I'll talk about that a little later. An MRI can be done, especially to find out the integrity of the anti-cruciate ligament, because if the ACL is not good, then you may not do a uni. And also it will tell you the condition of the articular cartilage. And if the patient has osteonecrosis of the femoral condyle, then an MRI can clinch your diagnosis. So these are the two main modalities which I will be covering in my talk, a partial knee or a unicondylar and a total knee replacement. Let's talk first about a unicondylar knee replacement. It is definitely gaining popularity. People are now moving away from total knee to a partial knee as long as it fits the bill, it fits the indications. And especially if you see the various centers, especially in Oxford, in UK, in Sydney, in Melbourne, in USA, in Boston, in Sydney and Melbourne, in Australia, Boston and New York in USA, there has been a kind of a trend, or there has been a bias to doing a unicondylar knee replacement. And therefore, the number of unicondylar knee replacements done are not uniform all across. So the basic indication for doing a unicondylar is the anteromedial osteoarthritis, and I'll explain to you a little more on that, and osteonecrosis, which is most commonly seen in the lateral compartment and in the medial compartment of the medial femoral condyle. What is important is to do a valgus stress view. If your single joint bed bearing or your varus stress view shows that there is bone and bone on the medial side, and after doing a valgus stress view, this particular joint space which is reduced opens up, as you can see here, and the lateral joint space does not reduce, indicating a good lateral compartment, then this is the patient who will benefit by a unicondylar knee replacement. Of course, you need to do a skyline view of the patella to see that there is no patellofemoral arthritis, and more so, no lateral patellofemoral arthritis. So, a valgus stress view is mandatory in deciding whether you can do a unicondylar knee replacement or not. And if you see the natural disease of the osteoarthritis, as I showed you in the initial slides, it progresses. So once your medial compartment is involved and you catch them at that stage, you can halt the progression to a large extent. But if not, then the ACL can get hampered, the ACL can become non-functional, and the lateral compartment also can get involved. So it is important to catch them young, as they say. The various advantages of unicondylar are it feels more natural, it gives better pain relief, recovery is faster, the kinematic and the patellofemoral joints are well preserved, and also the complications are less as compared to a total. And sometimes this one procedure can see the patient through the whole life as long as there is no progression of the arthritis. There are some contraindications. You cannot do a uni for all. If there is a varus deformity of 10 or 15 degrees or more, which is more so fixed, also a fixed flexion deformity of 10 to 15 degrees or more. If the ACL is deficient, the ACL has to be functional. That's mandatory for doing a unicondylar, especially if you're dealing with gout or inflammatory crystalline arthropathy or rheumatoids, then these are the not so good patients for doing a unicondylar. Obese patients, for me, is definitely a contraindication. A previously operated tibial osteotomy of failed uni, patellofemoral pain with lateral patellofemoral facet arthropathy is a contraindication for me. So now coming to the total knee replacement. When would you do a total knee replacement? And that's the final solution, friend. There's nothing after a total knee replacement yet. So when you've burnt all the bridges, when you've tried out everything, you've given the pharmacology treatment, you've given the injections, you've done the footwear modifications, you've tried everything, you've tried a HTO also, and that also has a certain life. And when you're burnt with all your options, then you do totally replaces. So what are my indications? So I have 3 indications. These are 3 clinical indications. One is pain, unrelentless pain, not being controlled by analgesics, injections, or any other modalities of physiotherapy. Walking distance is less than 500 meters. Patient is unable to really walk, go out, go and get his own groceries or go for marketing. And then activities of daily living are hampered, like going to the washroom, changing clothes, and all such things. So these are my indications for doing totally replacement, apart from, of course, the radiological and clinical indication. Radiologically, where you see it's a grade 4 Clegg-Run Lawrence. So, I need not take you through this video because these are all orthopedic surgeons who are watching it. This was a basic video explaining the step of a totally replacement. So I'll skip that. This is a patient in whom whatever you do, pharmacological treatment, injections, high tibial osteotomy, is not going to work. So it's a sure recipe for failure. So the only thing what you can do in such a case is a knee replacement. You can see the x-rays, you can see the pathological fracture on the left side, the subluxating joint. There is no way you can try anything else. So you've got to do a totally replacement with reconstruction of the bone defect, which is done by the KHS technique described by my father. And then this is how the post-op x-rays look. You see that the pathological osteoporotic fracture is bypassed and the bone graft has been in place and reconstructed with the bone graft by the KHS slot technique. These are the x-rays at 1 year showing that the fracture has healed. Patient is doing well, and this is the gait at the end of 1 year where you can see the patient walking comfortably as compared to what she was walking with the severe deformity. This is another case. Again, you cannot do anything. Not even a unicondylar is going to work in this case. And these are the cases where actually the amount of pain has a mismatch with the X-ray picture. If you just see the X-ray, you will feel, my God, the pain is too much. But in this patient, the pain wasn't too much. Actually, the patient was bedridden, though not able to walk, more because of instability rather than because of a painful joint. So that is what you have to know. These are the X-rays which you do, the varus stress X-ray, single joint weight bearing X-ray, long leg X-ray, and then these are the patients in whom a total knee arthroplasty is indicated. Not only a total knee arthroplasty conventional, but a total knee arthroplasty with some kind of constraint you've got to add. This is how it looks. These are the very classical neuropathic joints you see intraoperatively. You cannot miss them. And then what we did in this case was used hinge processes by Link, German-made processes. This was what you see the first stage. We didn't do a bilateral because the patient had more than 2 comorbidities. That is not in my dictionary a case for bilateral. So after a month, we went ahead and did the second side. The left side was also done with the hinged constrained processes. This is how it looked. This was the post-op X-ray. And as you can see here, this was a 3-month follow-up for that particular patient. And you can see here, patient came bedridden but could walk independently after doing a bilateral hinged constrained knee replacement. Just show you 2 more examples. A quick example of valgus knee. You can see the 30-degree valgus. There was a bone defect reconstructed with graft. This is the post-op X-ray where the valgus is corrected and the patient is walking comfortably. The last example, a windswept deformity, that is a varus on one side and a valgus on the other side. So we do see these patients, a 73-year-old. We did the one side first, as you can see the right, and the later, after 1 year, the other side was done, and this was a follow-up X-ray at 2 years. You can see the mechanical axis well recreated. So friends, there are a lot of newer technologies coming in to improve the longevity. Conventionally, we know that the joint lasts for about 20 years, but sometimes they are showing this oxenium metal helps the joint to last longer. Computer navigation improves the outliers and you get the mechanical axis recreated well. You can use patient-specific instrumentation, which became very popular about 5 years ago, but nowadays has gone out of fashion, if I may say so. The new kid on the block is the robos, and people are talking a lot about robos. I particularly have my reservations on robotics. I'm still waiting for the prices to go down, for it to be more, cost effective and at the same time user friendly. And then I would use it. Currently, I don't use robotics. We do have the OARM technology to see the component placement. So friends, as I come to the end of my talk, whenever you're dealing with osteoarthritis, first try the non-pharmacological therapy, then try the analgesics, intra-articular injections, and the disease-modifying osteoarthritic drugs as they are called. And the last part is to go for the surgeries. Dr. Shiva told us about the HTO, and you just heard when to do a uni or a total knee replacement. So this is a progressive disorder, osteoarthritis. Catch them in grade 1, grade 2 when you can potentially avoid a surgery. Have a multimodality approach. It's not that one size fits all. Use first try lifestyle modifications, give medications, injections, and the last thing you do is surgery. And Dr. Dheeraj showed you this slide. The surgery is at the top of the pyramid and at the last option when it goes to stage 4 and nothing else will help. But before that, at the bottom of the pyramid, you have so many options. So friends, as I said, only 15% of patients in your practice of osteoarthritis of the knee would require a partial or a total knee replacement. 85% can be managed by medications and by joint preservation techniques. So that is actually more important than knowing arthroplasty. So as I conclude, newer modalities will be introduced. Joint replacement surgeons like me will probably be out of practice in another 2 decades when they'll have more biological solutions. But right now, in early stages, stage 2, stage 3, unicondylar is the way to go. Stage 4, do a total knee replacement. Talk to your patients, understand their requirements. It's not necessary that total knee replacement is what is going to help them throughout. Talk to them, understand their expectations, find out their requirements, discuss with them the post-op do's and don'ts of a knee replacement. And then if they want it, then go ahead with a knee replacement. It's not always that your patients will be happy. So it's important to counsel them and discuss with them. Always be on the lookout for the new technology. Don't be the first one to use it, but at the same time, don't be the last one to use the new technology. With that, I want to thank Dr. Shiv Shankar for this opportunity, our dynamic president who is doing so many things, and also the team Abbott for putting this in place for us. Thank you very much.
Thank you, Dr. Sancheti, for that presentation. I request Dr. Abhijit to now start the Q&A section, please.
Yeah, thanks, Deeksha. Let's proceed to the Q&A session now. So we've got around 20 queries. I think we'll prioritize. We'll maybe take 10 to 12 of them. The first query is from Dr. Dipendra Roy. Dr. Dipendra Roy says that in acute pain with advanced OA knee, when there is severe pain, is there any specific analgesic which is preferred? And if Dr. Bijlani, maybe you could take that. So if any specific analgesic, if you recommend, then how long can we use it? And the second question he asks is that if there is a patient with renal compromise, then which is a particular analgesic to be used?
So there are 2 questions. The first question is, if the patient is not compromised renally or there are no contraindications to use, I would like to use diclofenac 50 milligram BD for the first 5 days at least, or a week maximum. And then I switch them over to either paracetamol or tramadol paracetamol combination. Recently, I have found a new drug. It's called Nifopam. The Nifopam I have found somehow to be very effective. And in combination with paracetamol, it works like magic because it has got least side effects, no acidity problem, and it can be easily given in a renal compromised patient.
Okay. Thank you, Dr. Bijlani, for that answer. The next one is again to you. It's again from Dr. Dipendra Roy. He wants to know whether intra-articular hyaluronic acid can actually be mixed with an intra-articular steroid, and does that give any advantage?
You are right. It can be mixed, but then we really don't know which one is acting. The person who advocates intra-articular hyaluronic acid will feel that the hyaluronic acid is acting. The person like me who advocates steroid will say that the steroid is acting. So it is very difficult to judge. Up till now, I have given 2 patients a combination of steroid and hyaluronic acid, but that's it. So my personal experience is not there, but many people, many of my friends who are doing this, they are giving both together, but then there is no evidence. There are no articles published that giving both together have a synergistic effect.
Okay. Thank you for the response, Dr. Bijlani. Another question, interesting question is of, how, everybody gives an advice of reduction of weight. But generally patients do not follow that advice. So what exactly do you tell your patients so that they get inspired to lose their weight?
As I told in my presentation, I tell them about the bariatric surgery research. That during the bariatric surgery, which came out only 10 years back in India, there was an article that if you lose 10 kgs weight, the knee pain goes away. Whether your knee is arthritic or not, that is irrelevant. So that is the thing which I am telling my patients. And not many have lost weight, but at least I can tell you that there are 10 to 15 patients in the last 6 years who have lost 10 kgs and their knee pain is just gone. They come with their relatives to me. That is how I come to know. They stopped coming to me. The only issue is that when there is pain and you're obese, you cannot walk anyways. So our target should be to reduce the pain whatsoever, whether by injection, whether by a steroid, whether by a hyaluronic acid, or whether by a surgery. Unless we reduce the pain, we are not going to allow them to reduce their weight.
Okay. Doc, the next question to you, Dr. Bijlani, for you again is that you talked about the fact that, for uncontrolled diabetes, it's like a contraindication for using an intra-articular steroid. Then in these specific patients who have uncontrolled diabetes, what injections, intra-articular injections do you use?
I would be very scared to give an injection in an insulin-dependent diabetes. I may not give at all, but there are people who are giving it. And what I can tell them is that you take insulin, get your diabetes under tight control in the next 2-3 days, send me your HGT reports. And after 3 days, if the HGTs are all 3 times a day HGT is normal, then I would go ahead and give them a hyaluronic acid injection or a PRP for that matter.
Okay, thank you. The next thing is that you spoke about, that in the last couple of years, possibly you've, shifted to triamcinolone as an intra-articular option for you. What dose do you use intra-articular triamcinolone in?
40 milligram. 40 milligrams standard dose. If sometimes the patient is very obese, like above 90 kg, then I will use 2 injections of 40 milligram.
Okay. Dr. Bijlani, the next sources, the next question to you is, you mentioned that, sometimes the animal source of drugs is a problem for you, for your vegetarian patients. So what are the veg source drugs that you use then?
So Rosehip is there and Univestin are there. Univestin went out of repute because of some article which I read, but I stopped using Univestin. But I still use combination of Rosehip, Devil's Claw extract, Boswellia serrata and vitamin C. Those combinations are very popular now. Many companies have them. So I use them. That is, they are, in fact, many patients, even in grade 3, grade 4, who don't want to get surgery, then they can just keep on having them for 3 to 6 months till they decide about the surgery.
Thank you, sir. Thank you for the response. Now the next question is to Dr. Shiv Shankar. Sir, Dr. Sunil Kumar Singh wants to know that he uses proximal fibular osteotomy, and he has found that it gives satisfactory results in his practice, and he would like to hear your comments on that.
Yes, proximal fibular osteotomy is one of the way of reducing knee pain. But only problem with that is it doesn't correct the mechanical axis, which is wrong. The varus mechanical axis, it is not corrected. So that is the reason why I have used in few cases. They had good relief, but unfortunately they didn't come for a long duration of follow-up to have my own experience. But there are people who are doing it, they're happy, so it can be done.
Okay. The next question for you is from Dr. Sri Prakash Jha. He wants to know which osteotomy plate is better. Is the distractor method better?
I feel distractor method is better for me because I have the total control over the outside the body, and the patient, the distractor is so robust. It's one good thing. It's made in India. It's designed by Dr. Mangal Parihar, and it's our own product. And I'm quite happy with that. And since the control is outside, I can keep on distracting till I get the desired distraction. That's the reason why I use it. But equally good is Tomofix, where you can do acute correction and put a plate also. But in that case, you have to be very correct in placing those, doing the osteotomy and distracting. And the cost is a little constraint for some of my patients. That is one reason why I'm tending to more towards fixator. Yes.
Thank you, sir. The next question is to Dr. Parag Sancheti. Sir, Dr. Ramit Dhalla wants to know, how does unicompartmental arthroplasty fare better over a full knee replacement?
Yes, so that's a good question. The various advantages of a unicondylar are that your cruciates, the anterior cruciate and the posterior cruciate, are kept intact. You do not remove them, and at the same time, the lateral compartment and the patellofemoral joint is intact. So it feels more natural. It can be done as a daycare procedure or a 24-hour discharge procedure. We allow immediate weight bearing. The patient gets back the range of motion quite earlier because the extent of soft tissue dissection is less, and the patient can get back to work early. Apart from that, the return to sports or activities like golf, double tennis, and doubles badminton are possible, and therefore the patient really likes doing a unicondylar as compared to a total knee, which comes with its own set of disadvantage as compared to a total knee for that select indication group.
Thank you, sir, for the response. So the next question is also to you. Dr. S.S. Jha wants to know if, Mr. Cartiogram, MR Cartiogram is of any help in the early stages.
Yes, it is. MR Cartiogram will definitely tell you, the extent of the cartilage damage, whether it is bone on bone, whether, is the ligament ACL intact. So a cardiogram on a 3 Tesla MRI can give you immense information as compared to a regular conventional 3T MRI without a cardiogram. And whenever you have bone on bone, whenever there is a medial compartment osteoarthritis, then only you should do a unicondylar, otherwise it doesn't give a good result. So MRI can actually help to find out the exact state of the cartilage. And more than the medial compartment, which is the more commonly done uni, the lateral compartment is also seen. And if the lateral compartment is involved and you do a unicondylar, then it's not going to do well and the patient is not going to be happy. So MRI cardiogram will help us to find out the involvement of the cartilage on the lateral side as well as the patellofemoral joint. So I think it's a good tool and an investigation to do, especially before subjecting your patients to a unicondylar knee replacement.
Thank you, sir. Thank you for that response. In a similar line, Dr. Jawahar Jetwa wants to ask you, Dr. Parag. He asks that, by using cartilage mapping, can we, use it for finding out the grades in early arthritis also? So grade 1 also. Because he says that sometimes grade 1 is severely painful and sometimes grade 4 has got still some amount of bearable pain. So do you use, in very early arthritis, do you use cartilage mapping?
That's a very good question, Jetwa sir, and I hope you're fine and doing well. The answer to your question is, in stage 1 and stage 2, I don't actually do an MRI because I don't feel it's necessary, but I'm seeing where the question is coming from Dr. Jetwa, because in these conditions, if you see that the cartilage is quite damaged and you're reaching the subchondral bone, and in a few weeks, probably it's going to be a defect, and then you're going to, so-called void the tide mark and go to the subchondral bone, then your options of certain injections or certain procedures is not going to be as good, because sometimes, even on the X-ray, you may see that it is stage 2, but on an MR, you can actually make out in early stages that is quickly progressing to stage 3. So I see from where he's getting and where he's coming from. I think it might be a good idea. But for my own practice, I don't do that. I rely more on clinical and weight bearing and stress X-rays to take that decision.
Yeah. Thank you so much, sir. The next query for you, Dr. Parag, is that it's from Dr. Vikas Singh. He says is that when you have bilateral grade 4 OA, do you prefer to do both the surgeries on the same day, or you wait for the first TKR and then when the patient recovers, you go for the second one?
So excellent question, Dr. Vikas. So let me give you my take on this. So either I do it same stage or then I do it 3 weeks later. So that's my, some people do it after 3 days or 4 days, but I'm not particularly a fan of doing it. Either I will do it in the same stage or then defer it for 3 or 4 weeks later. Now, which are the patients whom I would think of doing a simultaneous same stage bilateral knee replacement? The patients are as follows, and I have stringent guidelines. Number 1, age less than 70 years. Number 2, even if the age is less than 70 years, not more than 2 comorbidities. Number 3, I will very strictly assess the cardiovascular function. If the ejection systolic factor is less than 45, then he doesn't get bilateral. I would also do, in certain cases, a dopamine stress echo. If that is positive, again, they don't get a bilateral. If the patient is on dialysis and is going to require dialysis post-op, then that patient doesn't get a bilateral. And last but not the least, if the patient is not willing for a bilateral, don't force him to do a bilateral, go for a unilateral. So these are my indications, and I've learned it the hard way after burning my fingers to come to these stringent criteria which I follow. Even if the patient is 70 years and 1 day, I would not do a bilateral.
Thank you so for getting that clarified. The next question is again for you. It's from Dr. Jyotirmay Biswas. He says that in OA knee, on one side, with reduced medial compartment, what would you suggest other than a surgical intervention?
Yeah, so that's a good question. So joint space is reduced on the medial side. So technically this will be stage 2 or stage 3. And if the non-surgical options are to be mentioned here, then of course start with patient education, start with NSAIDs, footwear modifications, because many times OA knees, you always should check the foot. You will find it that it is deformed, it is invalgus or flat foot, then do the footwear modifications. Then if all this doesn't work, then of course concomitantly give the physical therapy. I particularly like to give IFT, it helps very well, or the short wave diathermy, and then go for injections. And if all this doesn't help, then you go to the surgical interventions. There are newer drugs, what we call as the DMOADs, disease modifying osteoarthritic drugs. And there are a couple of them which I like. I like using collagen peptides. I find them quite useful. I also like to use Dicerine. I like to use these newer drugs of glucosamine and chondroitin, even though the American Academy has told to you by Neeraj, don't recommend them, but I use them. And for whatever worth it may be, it helps me in 2 ways. It gives some relief, if at all, or at least buys the time before you can actually go in for an indication for a replacement. And I always feel that the patient should ask for the surgery rather than you sell him the surgery. So once you've tried all this, you know that the patient is happy and is ready to undergo a knee replacement.
Thank you so much for that. I think we now move to the last couple of questions. The second last question is to Dr. Shiv Shankar. This is from Dr. Vikas Singh. So Dr. Vikas Singh wants to know that in valgus deformity with less than 10 degree, will we go for a unilateral TKR or do we go for an HTO?
It's a valgus deformity. Basically, what we have to consider is how the other joint is. Just by knowing that there is valgus deformity, we know that there is a osteoarthritis involving the outer joint. We are not sure about the medial joint. We have to confirm the medial joint that they are good either by arthroscopy or cartilage MRI and so many other techniques. Then only we should proceed. And normally HTO we all have been doing for a varus knee. So all the techniques are very much evolved better for a varus knee rather than for a valgus knee. So that is also a problem one has to think before embarking upon any joint preservation surgery.
Thank you, sir. And the last question for today is for Dr. Neeraj Bijlani. Sir, Dr. Manupati Sharat Chandra wants to know if they can use 2 injections of triamcinolone at one time.
Yes, I have given 2 injections together, as I told you, in obese patients, that is one. And I have also given bilateral. But if you give bilateral, you have to tell the patient that you have to go home and take rest for 2 to 3 days. You cannot walk much. Anyways, whenever I give injection, I tell them at least for the next 48 hours, no climbing stairs and be at home. No need to take bed rest, but you can be at home, move about in the house only. Unless you stay in a bungalow, then I will tell them to move about only in the room.
Okay. Thank you so much, sir. So I think we have lots of more questions, but I think we have ran out of time. We're already 5 minutes ahead. And thank you so much for a very interactive discussion. To all the speakers, Dr. Sancheti, Dr. Shiv Shankar, and Dr. Bijlani, I think it was a very, very informative, interactive, and interesting talk. And looking at the interactions, I think there are another 30 more questions have come in. But I think clearly people have liked what has been shown today. So we'll continue to have you in future talks. Like we said, we have a series of 6 webinars. I would like to thank Professor Shiv Shankar for making this happen and really helping us out getting this program together, and Dr. Neeraj Bijlani for a wonderful talk, and also Professor Parag Sancheti for a very lucid talk and a very good interaction. So thank you so much. We'll see you in the next set of the programs. Also, great thanks for the Abbott team to have put this together, and also to the back-end team there. Thank you, everyone, on behalf of Abbott. Have a great evening.
Thank you.